and welcome to the Policy and Scrutiny Committee for Health and Social Care on the Monday, the 4th of September. Welcome, councillors. We have here Councillor John Nicholson. Councillor Rodney Down is going to be late, but he's coming. Councillor Warren Drew, Councillor Joe Lever, Councillor John Medland, Councillor Joe Robertson, Chris Hawkin and Joanna Smith from Isle of Wight Health Watch. At the back, we have Maggie Bennett, who representing Alzheimer's Cafe. Thank you for being here as well, Councillor. Sorry, Councillor Modstill. I'm still my brain. It's I'm getting of a certain age, Councillor Modstill. Michelle Legg representing the ICB. That need to check, it changes so often, Michelle. But Darren Cattell from the ICB is late, but he'll be back. Hopefully, he'll be about 6:15, 46, so 45 minutes. Leslie Stevens, welcome from the trust. Jess Entwistle from the trust. Oh, you're from the ICB. Sorry, it says trust there. So. Mark Howe, who's representing Laura Gordian, who's given her apologies, and Steve Cooper.
Joe Smith.
Oh, Joe Smith from the trust. That's mine. We've got. Sorry. Okay, thank you. And we've got, I think we've got Simon Bryant online, and we got Steve Cooper. Not yet, no. And we have here representing users, Paula Brisselden, thank you for coming, and Mary Montgomery from Isle of Wight Health Watch, and Louise in the corner from the press. So welcome, and welcome everybody online as well. Okay, I'll go straight onto the meeting. Apologies, we've got no apologies. There's no changes in membership. So we're all here, thank you. Oh, we got a you got a public question. We'll come on to it. Okay. Minutes of the last meeting. Can you look at the minutes? Can someone propose and second them? Propose, yeah. Councillor Medland, second them. Councillor Lever, are you happy for me to sign them? No show of hands. Yeah, thank you. Yeah, do you want me to initial them? Thank you. Any declarations of interest? So we go on to public questions. We haven't received any in writing. There's no one in the gallery, but Councillor Nicholson has a public question.
Yes, Chairman, it's an old chestnut and a new chestnut. The old chestnut is accessible information. I'm getting repeated concerns from residents that they're receiving appointments in standard type. And this has been going on for years, of course. It does beg a belief, really, because if we can't get something as simple as that right, then what hope have we for the more complex things? I've even heard that there's an optician in the town who thinks that accessible information doesn't apply to them and sends all their appointments out in standard type. That's the old chestnut. The new chestnut is not being able to get hold of, to speak to somebody at the ICB. And I'm told that in other areas of the country, it's quite easy. You ring the phone and somebody answers it, but it doesn't seem to happen with the Hampshire and Isle of Wight. So if perhaps we could take that away and take a look at it, the two very simple things that really are about customer service and should be better than what is being reported. Thank you.
And these, I believe, Councillor Nicholson, have actually come from residents or members of the public.
Isle of Wight residents.
Yeah, thank you. Councillor. I will bring it. Shall we bring it under members? Sorry. Which is the relevant paper? Yes, if you're happy for you to speak at that time. Can you make sure you've got a speaker thing? Thank you.
Thank you.
Yes, Michelle.
I just thought I would reply back to your two questions. I certainly will take back about the ICB contact. Is that across the ICB, Hampshire, Southampton, Portsmouth, or the Isle of Wight branch, so to speak?
It was an Isle of Wight resident, Michelle.
Okay, and I couldn't agree with you more about the print. The slight issue we have is that there are independent providers. So the optician you referred to, we can ask them, but it's up to them. You would think that an optician dealing with people with poor vision might be able to sort of think like that. I think we can look at that though, and definitely I will just take both those actions away and see what we can do. All right.
Thank you very much.
Can we have a written reply that also comes back to this committee?
Yes. You might just need to give me a couple of months or so I can get it round. But yes, a written reply, absolutely.
Well, technically, the next meeting is 3 months away.
Yes.
So
for the next meeting would be perfect.
Thank you. Okay, no more public questions. Item 5, outcomes and recommendations arising from previous meetings, pages 9 to 10. So we can sort of look at those. Just on the 111 service that was reported at the last meeting, we haven't received any information that was requested. We did request data from, sorry, it was Sarah.
It was Victoria
Victoria
White, I think, is who is the lead. I did email her to get an update, but I haven't had a response.
Okay, so it'd be good because it's actually, it's important to get the answers to some of those questions that we sort of raised, and particularly to do with the data. So if we could actually, that could be followed up. Thank you. The other item, Isle of Wight Strategic Partnerships update. It was promised at the last meeting that we would get a kind of grand diagram with the named individuals, and we haven't received that as yet.
Sorry, Chair, I emailed you the grand.
Not.
Yes, you did. Yes.
At the last meeting.
Yes.
Dr. Legg, Michelle, was the it didn't give all the links to the different, the trusts, the ICB, so that we actually had a plan and names of the individuals.
I think presently names are slightly difficult, certainly for the ICB, because we're doing an organisational redesign. And obviously we've had our mutually agreed redundancy scheme. And so I think names might be difficult, but not impossible. But certainly in the next 3 months, we should have some named positions. I'll check. I thought in our response, included trust structure, but why don't I liaise with Leslie outside this meeting and we'll get that sent to you again, all right?
Sorry, to know who people are that we can actually
agree.
have them. And then also it helps with this committee because then we can call those individuals to come along if we need to speak to them.
And similarly, from a trust perspective, things are moving very quickly. So I think we can give you names now from a group executive perspective. We won't be able to from a fusion perspective for another few months. So it's going to be a changing picture, but we can provide you with a here and now position and then update as things move.
Dentistry is obviously on the agenda, so is winter pressures. We had a very good meeting on the 25th of July, which was all the budgets and the current deficits and predicted deficits. I think, which remind me which councillors were there. I think in the meeting. I think Rodney, you were in there. I think Joe was at that meeting virtually. It was a very good meeting, and we got some very good information. And so what I'm proposing is that we sort of put it on the agenda in December, so sort of an update of that, because there was obviously some very difficult issues faced by the ICB and also faced by adult social care. So it'd be actually good if we could actually say at our December meeting, we've sort of got an up-to-date on some of the difficult decisions that you've having to make regarding the budget, the current and future. So, but if I can thank all the people that were actually involved in that, it was very comprehensive from the trust, the ICB, and from adult social care. Okay, is there any others that other members want to raise about the work plan? Sorry, the outcomes? No? Go.
Just to ask if there is a permanent fix now to the collection of 5 litre sharp bins. I know Michelle looked into it, and I do believe there was a resolution for the case in question organised by Wendy Pereira, but I don't know whether there's a permanent fix or whether that was just a one-off, because there's obviously more people. If GP surgeries are giving out 5 litre bins, then somebody needs to collect them. I think that's the case, Michelle.
Thank you, councillor. We don't hand out 5 litre bins. We use the 1 litre bin. The 5 litre bins, their collection comes under waste disposal or collection, which I understand is the council's remit.
Do you know if that's resolved now? You don't know.
I would refer that to you, actually.
Yeah.
Well, of that, to chase that up and get an answer to Councillor Nicholson.
Confirmation.
Yeah. Okay, we're on to item 6, which is adult social care complaints report, pages 11 to 24. Mark, are you going to speak on this, or is it?
I think we've got Helen Babington, who's our
Hello,
complaints.
Hello,
welcome.
hi. Hello,
Hi there.
yes. Hello, I'm the complaints manager for adult social care. So yes, it's my report, and I'm here just to give you an overview of that report, assuming everyone has read it, and take any questions.
Okay, any questions from the? I'm sure you've all read it. I've read it. Can I just say, Helen, it's a very comprehensive report.
Thank you.
And to actually thank you for it, because it is very detailed and it gives some very clear information of that. Does anyone wish to, things at Health Watch to?
Thank you. Yes, I just wondered how close we are to getting a single point of access for people that want to make a complaint about any health or social care service. Because at the moment, people can go to PALS at the hospital, they can go to the patient experience team, they can make a complaint about their GP via the GP practice, they can make a complaint about adult social care by going to the council. So there are many, many different ways of people making a complaint, and it's really confusing and can put people off from raising a concern or making a complaint. So is there any working towards a single point of access for complaints, which would make it far easier for people should they have a concern?
Thank you. Is that Joanna? Sorry. Is that Joanna at Health Watch?
Joanna from
yes.
Health Watch.
Hi, thank you, Joanna. It's a really important point that you raise, and I think it's a really valid point as well. I wouldn't be able to say how close we are to achieving that single point of access. The integrated complaint handling protocol is certainly in place, and that works and it's effective. We've got really strong relationships with my colleagues in the ICB and also in the trust at PALS and across that service. So when we do have complaints that are made that span all organisations, we're able to liaise, discuss and agree a lead organisation on that and provide a single coordinated response. That doesn't address the point that you're making about that single point of access, and I understand that. I'm part of the Wessex Complaints Managers Group, which is a regional group that involves colleagues across ICB, the Trust and councils across the southern region. And we've just worked together to renew the interorganisational protocol. That is something, the single point of access is something that's next on the agenda for discussion and moving that forward. But I can certainly ask for an update on that at the next Wessex meeting and feed back to you, Joanna, if that would be helpful.
That would be really helpful. Thank you.
Rodney, you've got a question.
Oh, thank you. Yeah, I just want to, when this single point of access gets sorted out, will there be, I hope that it won't be absolutely everything online, because people just can't manage that. And not everybody has internet access. What about blind people as well? How are they going to do it? Thank you.
Thank you. Yes, I think accessibility is a real key point, and it's certainly a key point for me in complaints. I know that with the agenda of moving a lot of things online and the online option being default is something that I strongly disagree with for all the reasons you've just said, Rodney. There's lots and lots of people who for them that just doesn't work, and I'm very resistant to the default online option because there are all sorts of ways that somebody is more suitable for some people, and somebody should be able to make a complaint in any one of those ways. So I'm fiercely holding on to our paper forms, the telephone as well, and things like that, because we've got to make sure that accessibility means exactly that. It's whichever way is best accessible for that person. So I hear you, and I am a fierce defendant of paper forms, I'm afraid, much to my colleagues' dissatisfaction sometimes with their default online position. But the people we work with, it doesn't suit them, the majority of them, in fact. So we have to make sure we maintain those other access points as well.
Thank you very much indeed.
It's a very good point, Rodney, and perhaps you'd like to make a proposal to the committee later on about that we support Helen in keeping paper, other means of accessibility to complaint other than online.
Oh, thank you, Chairman. The only proposal I've ever made before is when I proposed to my wife.
Well, you can try tonight, Rodney.
It would be
Uh,
really helpful if that support did come from members as well, because sometimes I feel like a bit of a lone voice in the online world, but it would be really helpful to have your support behind that as well, and the rationale behind that.
Thank
Thank you. Yeah, I mean, I just want to endorse what Helen said. I mean, given the population of people we work with have a range of disabilities sometimes, and we have to communicate in very different ways. Like Helen's saying, we will communicate according to their needs so we can effectively engage with them. And like Helen endorsing that, you know, we are still holding on to some paperwork to ensure that we communicate with people in the best way possible. And I think that's really important. The telephone, yes, there is the online, but there is other forms of communication that we can use if people have difficulty in terms of sight, in terms of hearing, and we continue to work in that vein, and we absolutely should, because most of the people that we work with have a range of disabilities and more comfortable using basic communication to deal with the challenges they face day in and day out. Thank you.
Thank you. Joe, you had your hand up, and then John. Sorry, John, did you want to make a question in a minute? Okay, Joe.
Thank you, Chair. I've just got a few questions. The first one's a pretty simple one, I hope. It's point 17, significant increase in complexity of matters. I was just curious what was causing that. Is that just a hangover from the pandemic, or is that other things?
I think that's a trend. It's a trend seen certainly across our southern region. Complaint managers discussions always highlight the same sort of trend in this increase in complexity. I think it's linked in with that. There's elevated levels of dissatisfaction and persistence that we're also experiencing, and I think, yes, to a certain extent, it's a leftover from COVID, the period of COVID, and coming out of that period. I think at the time, and certainly my annual report straight after the COVID period, where everyone saw a reduction in the numbers of complaints across the region and certainly nationally, as did the Ombudsman. It was certainly a time, COVID was, where there was a new public appreciation for public services, and that saw a reduction in complaints. It's steadily grown again since that, but coming out of that period of COVID, it certainly changed the landscape of complaints, and that's what we're seeing, these elevated levels of dissatisfaction and persistence, and the complexity of matters that people are bringing to the table. So I can't be any more scientific than that, really, and other than to benchmark it against what other authorities are experiencing, which is the same. But yeah, it's certainly coming out of the COVID period, it's changed the landscape of complaints in those terms.
Thanks, Helen. And related to that is, I'm looking at the upheld and partly upheld complaints. There's a few examples there. I know from my perspective, I'd love to see the trends of complaints, the themes of those complaints over years, so we can see if we've got various sticking points in certain areas. That would be really good to see from my perspective. Finally, sorry. Go on, Helen, respond to that if you like.
Oh, I was just going to respond to that bit, actually. Certainly, the para 34, the types of complaints upheld, partly upheld, those three themes are the trends. They're the communication. There's always an element of communication somewhere in a complaint, whether that's upheld or not upheld. It's certainly communication, provision of advice and information, and delay. Those are the three main themes. They're quite consistent themes if you look over the years of back over the annual reports. Those three themes are quite consistent. That's the nature of our business, really, those three themes. So it's not surprising that those are the themes of complaints. With the best will in the world, we're always going to get complaints, and that is why those are the three main themes of adult social care complaints, because that is our business. It's about communication, and it's about advice and information and providing that advice and information, and it's about timeliness of action. So that, like I say, those are they've got our reoccurring themes in most annual reports.
Okay, thank you. And I guess on the back of that then, there's some mention of learnings from the complaints, but how do we measure if those learnings are effective or successful? If like you're saying, it tends to be one of those three things, how do we know if what we're doing is successful from learning from that?
The learning from complaints, we at the end of every complaint or appeal investigation, the investigating officer has to complete what we call a reflection and learning framework, and that identifies exactly what it says. It's any learning, any actions that need to be undertaken, but also, even if a complaint is not upheld, there's always an opportunity for reflection on a not upheld complaint, to understand how we've got to the point of a person making a complaint, and there could be opportunity for learning even if a complaint is not upheld. That reflection and learning form, any actions that are identified, the investigating officer takes responsibility for addressing that action and putting that into place. Although we've got those broad themes that are reoccurring themes, the detail underneath each of the complaints, we don't, because the learning actions are followed through to completion, and we follow that through to evidence of completion of that learning action. So if there's a new process required, if there is a letter to be rewritten, if there is a system update, we follow that through until we've got evidence of that being put in place. To finalise the complaint record, if you like, that complaint record is still open until that learning has been evidenced that it's been put in place. So we can be confident that those steps from that particular complaint, that particular detail, have been addressed and put into place. The reason that the themes that we've talked about there, the communication, the delay, the provision of advice of information, are really broad themes. So I would say we tend not to get repeat offences within those themes, because we follow the learning action through in a particular complaint to completion. But that's not to say that the theme of communication doesn't reoccur in different pockets in the service, in a different team. So it's about dealing with that on a case-by-case basis, and each complaint can be very, very different, albeit fall under the same theme. Is that helpful? Or
It is, thank you, Helen.
Yeah, no problem.
Councillor Nicholson?
Chairman, I think that I'd like to make a proposal that this committee recognises, appreciates and supports the sensitive and considerate manner in which adult social care handle their complaints. Complaints is a bit of a misnomer, really, because it's about feedback, and I think from what Helen and Mark have said today, you can quite clearly see that. So I'd like to make that proposal and support stealing Rodney's thunder, if I may, Rodders.
Of course.
We're separate and Pacific, but I'll take this proposal. Can we just leave that there until we get the other questions in, Councillor Nicholson? And then we come back. So we've got two possibilities of proposals. Councillor Midland?
I had actually worked a proposal in line with what Councillor Downer said, and that's what I was going to propose. But I mean, I think yours is a separate proposal there. So I think we have two proposals now to be put forward. I would, while I'm here, I might as well second Councillor Nicholson for an excellent idea. I think we could take that proposal now and then perhaps take mine and then move on.
Can I just
say it's not so much a question, it's really a statement. It's linked to complaints, but it has a wide application. I believe that every policy which has a direct impact upon the public as a whole, individually, collectively, must be based upon the principles of social inclusion. In other words, not suddenly to make it all network, all, you know, on the internet and that sort of thing. But whatever you make a policy, it must be easily transcribable to anyone who lives on the island. Just a statement, that's all.
Helen, did you pick that up from Chris?
I did, yes, I did. And I think we, again, a really valid point and something that we bear in mind in adult social care with our co-production agenda, which we're moving forward, which is placing people at the heart of that development and decision making. So I think it's a really valid and important point. So thank you.
We'll move to the two proposals. We've got yours first.
Chairman, could it in fact be, if we merge the two proposals, could it in fact be one proposal? I think John's got them written down, haven't you?
Okay, John, have you written both down?
I have not written both down. I've written down the one that was actually reflected what Councillor Downer said.
Okay, so we do that. Can you repeat that one first?
If I propose this committee endorse the continued use of ensuring that complaints can be made by post or telephone in addition to digital communications to ensure accessibility.
Okay, can we?
Chairman, if that went on as a second sentence to my proposal, then it can be rolled into one proposal.
I'm very happy with that, yes.
Proposals. Repeat them back so everybody knows what they're voting for.
So my understanding is that the committee recognises, appreciates and supports the sensitive and considerate manner in which adult social care handle complaints and therefore endorse the continued use of ensuring complaints can be made by post/telephone in addition to digital methods.
That captured it?
Perfect.
Good. The proposal from Councillor Nicholson. Do I have a seconder? Councillor Midland. Do we, a show of hands that we agree with the proposal? So thank you, Helen. And thank you for your very good contribution tonight and a very good report. And we totally are unanimous in support that we want to keep things on paper on the telephone and not go into just an online complaint system. So you've got our full support on that.
Thank you. And I'd just like to thank the committee for their support with this area of work. It's not always straightforward, but your support is really appreciated. So thank you.
Thank you. Okay, we go on. We've had a slight adjustment of the agenda because we're waiting for Darren Cattell from the ICB to particularly be here regarding the patient transport. So I'm moving that, if you're in agreement, to item 9 because it's quite important that he is here. So we're going on to update on dentistry, pages 31 to 44, and you've got the report also from Isle of Wight Health Watch. So if we start off with yourself, Simon, welcome.
Thank you very much, Chair. So my name is Simon.
If you can introduce your report and then we can go from there. Thank you.
Yep. Can you hear me in the room?
Yep.
Yes.
Take that as a yes. So the report that you've been provided is the ICB's response to the Health Sec Committee recommendations around dentistry. And I am assuming that you have already understood the points. I suspect it is not particularly earth-shattering for those in the room that we've agreed with most of those points. If you are willing to let me give you perhaps an update of where we are as a result of that and our vision and direction for dentistry across Hampshire and Isle of Wight, but particularly pertaining to the Isle of Wight, I think you might find that a little bit more informative than just the paper as it stands. Would that be okay?
That would be wonderful, actually. We'd like an update.
I thought you might be. So we've taken on delegated responsibility for commissioning community pharmacy, optometry, and for the businesses I'm here and the dentistry. And that fully came across, the last elements of that came across the ICB in July. So obviously of those three, it's probably not a great surprise that dentistry is our priority. It's in a state that I don't think anybody's particularly happy with. And so we need to move forward on that one as best we can and as quickly as we can. We have got to a point to a final draft for a strategy. And out of that, we are looking to take forward 3 key themes to the ICB exec for support going forward, which will impact on, we hope, improving dentistry on the Isle of Wight. I think at this point it's worth saying I need to manage everybody's expectations. I don't believe it is in our gift in the short term to improve dentistry. I think what is in our gift in the short term is to stop it getting worse. So from that end, I think we need to stabilise what we have. And the first paper that will be going to, that I'm going to talk to you today, that's going to the exec team, is to stabilise dentistry on the Isle of Wight. The Isle of Wight has been highlighted as an area that needs improvement in dentistry. We are challenged by the number of dentists that you have on there and the access, and that's equally highlighted within the report from Health Watch that you've got. So we are looking at improving access. But at the minute, because of the way that the contract works, we have dentists being paid different amounts for the same activity across the whole of the Isle of Wight. So we could have, and I don't have the exact figures to hand, but as an example, we could have dentists within a mile of each other being paid completely different rates for the same activity, which clearly is not as it was intended, I would suggest. So initially we need to aim to stabilise that, because if we were to bring in new dentists, they would be on a potentially different rate. And what we see elsewhere where we bring in dentists, we start to see a bit of a domino effect, whereby you steal resource for a new dentist coming in, which isn't helpful for anybody. So we need to get that stabilised so everybody's playing from a fair playing field to start with. It might be of interest that in a recent procurement exercise where we were looking for a new dentist on the Isle of Wight, we had no expressions of interest. So we need to look at why that is the case, and to make it more attractive to new partners to come into the Isle of Wight to provide dentistry. So that's part of that whole dentistry, that stabilisation piece for the Isle of Wight. In the meantime, obviously, if we can't get activity from your normal high street dentist or whatever you want to call it, we need to try and get something over there in the midterm to actually support that before we can build those in. So we are looking to scope out a dental bus that will be used across Hampshire and Isle of Wight, of which obviously the Isle of Wight is a priority area. That will give us the ability to bring in some more access onto the island that allows those patients who currently can't see an NHS dentist to actually support them to become dentally fit, at which point we hope to have more access to dentistry. So if you look on the NHS Find Me a Dentist page, you'll often see dentists saying they're happy to take patients referred into them by another dentist. That's because they have limited access, but can bring somebody in who's dentally fit. What they struggle to do is to see somebody that has large problems and able to be able to treat them. So if we can use the bus to actually come to the island and improve the dental fitness of patients, we can actually make best use of the capacity that we have on the Isle of Wight. And finally, we are looking and currently working with Portsmouth Dental Academy to scope out a centre for dental development. This will allow us locally to start to create our own healthcare professionals in terms of the dentistry field, of which we know if we train locally, a greater percentage are retained locally, and discussions about potentially having that as a hub and spoke model. So we would be training dentists on the Isle of Wight as we would in Portsmouth, as we would in Basingstoke, Southampton, etc. So we can start to create our own dental professionals within our own areas to look after our own patients. So they're the three main areas of what we're trying to push forward. It's as I say, it's early days yet. I don't think we are going to turn this tank around overnight. But hopefully there are three themes that you can support. I see that the intent of the ICP in terms of taking on dentistry will hopefully improve matters. I think I'll take a breath now and happy to take any questions.
Well, before we do that, I think it'd be good if we, Isle of Wight Health Watch, in your report, might wish to make some sort of a comment. I know that we've got some various questions that we want to ask.
Yep.
Okay, Joanna?
Thank you. So I just want to start by saying it's really positive that there at last we have some hope on the horizon, because for many years we've had nothing to say to people that contact us. People contact us almost on a daily basis, begging for help to find a dentist. And for the past 5 or so years, we've literally said, we can't help you. There is no one. Your only chance is to go on the mainland to try and find an NHS dentist. And I'm really pleased that the Isle of Wight is seen as the priority. It absolutely is, because things are definitely worse for island residents than on the mainland. And I would say at the moment, things are getting worse on the island. So 5-6 years ago, people would come to us and struggle to find a dentist. Now they're coming to us and struggling to get urgent and emergency care. So we're having people waiting up to 3 weeks for an urgent appointment. And then they'll get that urgent appointment in 3 weeks. And in the meantime, they may have to go to their GP, to A&E. They may call 111 because they're not able to cope with the pain. And sometimes infection they've got. And then they'll get an urgent appointment and their problem isn't treated. It's fixed for the time being. So the person may be given antibiotics or have their tooth removed. So that their dental problem isn't resolved, and it may reoccur sometime in the future, which is what's happening to people. They're in this never-ending cycle because they can't get regular dental care. They're in a never-ending cycle with emergency and urgent care services, and that's not good for them, and it's not good for the urgent care services either. So, you know, from what we hear from people, it's still a deteriorating position on the island.
Thank you. I suppose I've got a question for you, Steve, from what Joanna said, and then I'll open it up to members, is when will islanders have access to an NHS dentist? You said that you've got to do certain things first, right? But is that going to be 2025, or is that going to be 2026, or is it going to be 2030? But where are islanders going to get the equality of the mainland residents in having access to an NHS dentist? Because I know a huge amount of people, including myself, that don't have an NHS dentist, right? Within that, and in fact, I'm sure with my colleagues as ward counsellors, I get weekly people asking about where do I go for a dentist. So when can we put a date on it and say, you know, the government are doing this with things like carbon footprints. Actually, more average islanders want to know whether they can have a dentist than probably the carbon footprint, although important. Can we give a date tonight from you, Steve, to say you are going to target a date so that islanders have access to an NHS dentist?
Is that aimed at me?
Yes. Sorry?
And you called me Steve, that was all. So I will have to be honest with you, and I think that is dependent on things outside of my control. So to come up with a specific date on that, I think we need to see what the dental reforms come through and provide us with, because that will very much change the landscape. I think if nothing was to change, I would like to see improvement within a year to start to see increased activity either through the dental bus or through increased procurement. That is dependent upon healthcare professionals being available to the Isle of Wight. But I think we can get the bus in there to start with and start to improve those things. I think beyond that, we are dependent upon the Centre of Dental Development being available within Portsmouth and used locally, but that's probably looking at a 2-3 year term to get that up to running, and potentially for that wouldn't be dentists, but it might be other dental professionals to support. Dental technicians can do a large percentage of what a dentist can do. So we can start to see improvements, but to put a figure on when everybody can have access to an NHS dentist, I think that's challenging given the actual state of the contract, bearing in mind patients don't even have a registration with a dentist currently. Whereas we talk about registration with a GP, you are only with, inverted commas, a dentist whilst you're undergoing a period of treatment. There is no guarantee that for those in the room or any of us that are lucky enough, and that doesn't include me either, to have an NHS dentist, you are not registered with a dentist, so there's no guarantee that tomorrow that dentist can't see you, because they have no requirement to see you. They have no registered population. So it's a strange ask and a strange situation we're in. But to give you a date, we're probably looking 4 to 5 years away to getting significant increases to where we really want to be. And that's by having sufficient capacity across the island where all of those dentists are starting to deliver, and we are starting to see patients no longer attending GPs, no longer attending A&E. But I can't be definitive to give you a specific figure, because we are reliant upon things outside of our gift.
Thank you. At least there was a bit of indication of 5 years, which I picked up.
I'm retiring in 5 years' time, which is probably why I chose it.
From members, all hands are going up. Councillor Lever first, then Councillor Drew, then Councillor Downer.
Thank you, Chair. I was going to ask a similar line of question to yourself, talking about dates. I appreciate the strategies. Essentially, obviously, there's a short term, which is stopping getting things worse, which is inevitable, I think, and then we'll have a longer term thing. So instead of just sort of asking for some final date, it would be really good to sort of understand a timeline of milestones that we're looking at. So, for example, the draft strategy, when will that just become the strategy? What is the short term? Is that a year, 2, 3 years? And what are the milestones that we're going to hit to get to the destination we want to be, essentially, so that we can scrutinise that? Because seeing quotes like "my son ended up pulling out his own teeth and I've just had my dentist appointment cancelled for the 4th time," it's a pretty grim situation we're in. So I want to be able to scrutinise some timelines. Thank you.
Yep. So I think what we can do for you, once I've got the strategy agreed through the ICB exec, I think I can come back to you. I think I heard your next one is in 3 months' time. So
yes,
if you're
it's in December.
If you're happy for me to return in December, I'm happy to come back and we can discuss the strategy once it's been agreed by the ICB. And at that point, I can give you some further timescales or even some good news on some of the proposals going forward in the three items I discussed. Would that be something you'd be appreciative of?
That'd be excellent, Simon. Thank you.
I think we can do that then. That's probably the best way forward, I think.
Councillor Drew.
Thank you, Chair. It's probably something of an obtuse question. I don't really understand the quite baroque nature of commissioning in relation to this. It seems an absolute labyrinth, and there are probably all sorts of reasons. But I was just wondering, going to the point that Ms. Smith made in relation to emergency care of dental provision, is there any reason why, and I'm sure there probably is, we cannot have an emergency care dentist, for example, at St Mary's, who would be there to potentially triage the very worst cases, so that we don't have these anecdotes of people pulling out their own teeth? Is there some aspect we can look at?
So I would say the main challenge to that would be workforce and actually having people available to undertake that. We have I think I would completely agree with you, having previously been a commissioner of primary care medical services within Portsmouth, to come into the dental space. I think I would suggest it's been challenging and such a different way of doing commissioning of healthcare, that there are so many unintended consequences of that. Whilst I don't support the endpoint we've got to, I do have a greater appreciation how we've ended up here. Now I have a greater insight into how it's commissioned. So I think to improve urgent care would need, as along with general dental services, an improvement in the workforce that we really need to get through as a longer term aim to actually solidify this. Because ultimately we want to be in a space where we've got better public health, and I've met with Simon and the other directors of public health to discuss how we can improve that. Ultimately, a large proportion of dental treatment is avoidable, and then if we can get sufficient access, hopefully the need for any increased access to urgent care isn't then needed, because we're getting it at the point it's needed, so we should be reducing it. So whilst I think we need to look at urgent care, it's not where we need to be. I think we need to look at the mid to the long term to actually stop people needing the urgent care as much, and get the dental services out there.
Thank you for that. Councillor Downer.
Oh, thank you, Chairman. I'd just like to ask a question about this bus. When's it likely to come over here, and how long is it going to be over here for? Thank you.
So what I don't want it to do is spend most of its time on a ferry. So the proposal is likely it will be coming over at weeks at a time. It is, and our proposed model is via a dental charity that can provide this, and they've got a well-trodden path of doing this elsewhere. So when it is over for a while on the Isle of Wight to actually support the care of the patients over there. It's not going to be coming and going every 5 minutes. It's going to spend a significant period of time. Obviously, I've got other areas of need across the whole of Hampshire and Isle of Wight, so we'll need to have that bus in other areas. But it's not going to be coming over for a day or two, because that's wasting everybody's time and not actually helpful to anybody, I suspect, if it's just forever moving.
No, thank you.
Chris, do you have a question?
No, I'm just, no questions, but I'm actually looking, Chris Jarman's got his hand up, that's all.
Councillor Jarman, you've got your hand up. I presume you're there virtually. You want to click in?
Yes, thank you. Thank you for unlocking my microphone. Yes, a couple of questions, and I have to declare an interest here because some of these are personal things and others have been referred to me, as they have indeed with you, Chair, from my ward members. The first question I have is really a procedural one. Is why is it that NHS registered dentists, for example, my dentist on the island, are able to refuse their NHS patients, for example, one with a broken tooth and in great pain, access to available slots, unless they agree to be booked in as private patients? How is it that they're allowed to do that? Particularly when in at least one incident, which occurred just a few days ago, the individual dentist had multiple available slots the whole of that week, including at 4 p.m. on the very afternoon of the telephone call. So how is it that they can, what would appear to many, I'm sure, to be effectively blackmail patients into coming as a private patient or being refused treatment when they have available slots and they are an NHS registered provider and the patient is registered with them as an NHS patient?
So I'll just clarify the very last sentence that you had. You are not registered with a dentist. You are only under a dentist for a period of care. When that care ends, there is no requirement for them to take you back.
So if I can just interrupt there, when the dentist advertises online that they're now taking registrations for NHS patients, and one goes along to them and registers and fills in their form as an NHS patient, is that not registering with them as an NHS patient?
That is their wording. There is nothing in the contract that says that. There is no requirement for them to hold a register. They use that terminology in the way that they work as a business, but there is no registration in the same way as there is with a GP with a dentist. So there's no requirement from that point of view for them to actually take you on as a patient. You could have done regular checkups for the past X years and then find at your next checkup they say, sorry, we're full. So there is no registration process within dentistry as there is in other places of healthcare. That's one of the challenges that I found when I first came to dentistry that I'm still scratching my head over. Now, having said that, I would expect a dentist who is seeing a patient regularly and that patient was in demand of dental care and they had space to carry on to see that patient. I don't think that's appropriate, and I don't think that is something that I would reflect on as a healthcare professional, albeit I'm a pharmacist. I would like to see from other healthcare professionals. So it's not something I would like to see. And certainly to say to patients, I have, or for the patient to be aware that they have open NHS bookings that have been seen previously as an NHS patient, then be told you'll have to go private, is not something the ICB supports. So if that can come across to me, we can pick that up with the individual provider and see what the actual situation is from their point of view, if they're happy to forward that to me. I say it is not, having said that, it is not uncommon for practices to change the mix of the professionals within that practice, some of which will be private, some of which might be providing NHS care. And at sometimes you see people effectively drop off access to that NHS care. And if they still want to go to that practice, then the practice might say, we don't have sufficient ability to deliver the NHS care that we want. So the only option to come here is to go privately. I don't think that's particularly helpful either, but it is the situation we're in, as these are individual businesses and they're allowed to run that as they do, unfortunately. I'm not sure that exactly answers your question, but I think without specifics, it might be a little bit difficult.
Well, thanks, Simon. I'll certainly forward you on the email thread. But so just for clarification, I think it would be exceedingly helpful if there were to be some form of general information sent out to islanders to tell them that whilst they might believe they're a registered NHS patient with their dentist, that they're not, because I don't think most people actually understand that. Clearly you were questioning it, I've questioned it, most of the people in my ward have questioned it, we just don't get it. Why we would fill in a registration form and then not be registered as an NHS patient, I don't know. But I do feel that we are under an obligation to tell the population of the Isle of Wight what the truth is. And if what you're saying, I believe you completely, is the case, we should communicate that to the 140,000 people on this island. And Councillor
Jarman, I'm very conscious of time.
Yeah.
I think you've made your point. I think we can pick that up perhaps in one of a resolution regarding that, because I think we're all pretty shocked about that. I think I didn't know that, so thank you for answering that. Is there any final other I have two final ones to put, Simon. It seemed recently that Southampton and Portsmouth got sort of allocation of units, right? To have the right terminology. Perhaps Joanna can come in this and correct. But the Isle of Wight hasn't. Perhaps if you could explain it better to me than me, Joanne.
So it's around the units of dental activity. Sorry, Simon. Dental activity is commissioned based on banding, depending on the kind of severity of the treatment. I think Simon mentioned before, and it was before Simon's time, to be fair, when a tender was put out on the island asking for a dentist to provide thousands of units of dental activity, but that size of contract was very big, and I think that was one of the contributory factors as to why dental providers over here didn't want to take that on, because it was too big. And my suggestion would be that it would be good to speak to dental providers to see what they can deliver, even if it's 1,000 units of dental activity. If we got 10 dentists that could deliver that, that would be far better than nothing.
Yeah, to just support what's just been said. It's not really an excuse. It's before my time, too much with it, because we are still the NHS and we're trying to improve services. I have gone back to the commissioning team who are now embedded within Frimley that still work across the whole of the region, that in terms of increasing activity, I'm not looking for perfect. I'm only looking for better at this point in time. So if that means somebody taking on 500 UDAs or 1,000 UDAs or 2,000 UDAs, I'm not really concerned, so long as they're taking on additional UDAs as best we can. And if that means going out and ringing up individual providers one by one and saying, how many can you take on? Could you do some more? Then so be it. Let's ring round and engage with them. The recent Health Watch engagement event that we had was actually really reassuring that those dentists that are providing NHS service are really wedded to it and want to improve it. But I think we need to help them to help us.
Thank you, Chair. Given that obviously if there is any extra provision for UDAs and such, how do we triage the most difficult cases? How do we make sure, given that there is such a dearth of supply, that it's not simply those with the sharpest elbows who are potentially getting that supply? Is there something that we can implement which is going to assist those people who are in the worst situations?
I don't believe there is easily. I have asked the same question for another part of the for the Hampshire and Isle of Wight as a hypothetical case. If I was to put a new dentist in the most deprived area of, say, Portsmouth, how could I stop people from Chichester from coming and accessing that service? And the answer is, not only is it not easy, you can't. You are funded to provide services on your patch for anybody in the UK. So I cannot prevent people from the perhaps more well-informed, the more affluent, the more those are able easily to travel to actually access those general dental services. So the dental bus will achieve some of that by going into those places and hopefully getting those patients referred in. But in terms of being able to prioritise that care, bearing in mind what we said previously about patients not being registered with a dentist, it will be incredibly difficult. I don't know what I did in a previous life, but it wasn't very good.
Sorry, Joanna. Oh, Joanna, then Mark.
Sorry, I'll be quick. I would suggest there's a pretty easy solution to finding the ones in most need, because that's such a good point and it's absolutely crucial. And I would suggest that the commissioners work with partners. Leslie, I know that our partners at Citizens Advice speak to many people with mental health and substance abuse problems who are in significant distress. So working with partners around the table, I'm sure the looked after children team as well. There are many of us that could come up with people that absolutely need prioritising.
I don't think that the challenge is identifying those priority groups. It's directing the service to those priority groups and making sure those groups get the access and isn't taken away from them by those with, I think it was told previously, the sharp elbows that get in first. I don't think there's anything within the contract that allows us to prioritise those groups. We can prioritise where those general dental services are, and we could potentially put out comms and make it easier for some of those groups who, by definition, find it more difficult to access healthcare in totality. But I'm not sure there's anything within the contract that says we can hold this general dental service for these patients only.
Okay, Mark, you wanted to speak, and then Darren.
Thank you, Chair. I mean, I think, and this is not a dig at Simon, but for me, it's when you look at people's lives, particularly those we considered vulnerable, and particularly, I think Joe's already highlighted that. Good dentistry or having good set of teeth means you can eat, you get nutrition, you're less likely to feel, less likely to have a number of different conditions in fatigue, you could fall, you could do all sorts of things. So it's some of those basic things. We talk about feet, but we're talking about dentistry here. And I think for me, it is about that more targeted approach to those, we've mentioned complexity today, those individuals in our communities who desperately need to have good dentistry in order that they can have a quality of life, a quality of existence, and do the basic things that some of us around this table, including myself, probably take for granted. So I think it's really important. It links to JSNA, it links to looking at health inequalities, it links to targeting people out there in our communities who need that service now. And we need to support each other collectively. And again, it is about partnership. It is about joining commissioning. It's about working with health and social care and other elements of the service, and particularly those user groups that will be incredibly vocal when we look at these sorts of things. It's really basic, good teeth, you can eat your food, you're not miserable, you're not suffering, and you're less likely to come in our direction in a sense, and you're in more control of your life. Thank you.
Thank you for that, Mark. There's a lot of studies about oral and mental health and the link. And being someone that worked with people for many decades in the mental health arena, the people that were in the biggest distress had awful teeth and had a lot of pain. And so the two things, should be together, and we should be working those together. Darren, and then I'm going to bring it round.
Thank you.
Conclude.
Thank you, Chair. Please, colleagues, accept my apologies for being late travelling back from the mainland. Simon, I think you've given us some hope with what is a long-standing challenge on the island. However big that hope is, I think there's more that we can do. And I think somehow there needs to be a balance between understanding the contractual position, understanding the legal and commercial aspects to private business, with the moral and ethical dilemmas that we face on the island. And somehow outside of this meeting, we need to bring those two things together to do more for our island population, given all the reasons that people have said. How and who and when we can decide outside the meeting, but I think we need to do something rather than just say it's, Simon, I'm not paraphrasing your words, but it's just too difficult because the legal position is one that supports the provider. We're here for the population, aren't we? So we'll have a conversation, Simon, and involve a number of others and see whether we can get that balance and do something.
Thank you. I'm going to bring this together, and I'm, from the chair, going to try and put a proposal together, because I think we all agree in this room that this is an awful situation. No reflection on you, Simon, doing your best, but I think we have to actually say on the island, this is a priority health issue. And we need to actually, so my proposal is that this committee sees dentistry and the improvement of dentistry on the Isle of Wight as a high priority, and that we wish to make this be on the agenda of the Integrated Care Board, right? Partnership Board, as a main agenda item at a future meeting. And this committee is sort of speaking on behalf of residents of the Isle of Wight who desperately need answers on a not only on a long-term strategy, but also on a short-term strategy of helping the most in the priority need. Is that, don't think I've captured that? So, Warren.
Thank you, Chair. I think that certainly goes very much to the point of what we've been discussing. One of the things that I'd be interested in looking at potentially is starting a piece of work, going to some of the issues that Simon raises regarding how we can structure and how we can triage access, so that we can perhaps understand a little bit better about what are the issues that constrain us, what are the issues that constrain the ICB, how can we organise things such that we can provide provision if there is greater resource forthcoming from whatever direction, how we can make sure that that is earmarked for the most desperate, as it were, and potentially seeking advice externally, possibly. I don't know where that would necessarily come from, but I think it's a good idea to, I suppose, ventilate things a little bit more thoroughly. That's probably a little bit too wide to be incorporated into a proposal, but I think I'd be very interested in looking at some type of focused group as to some of the issues that have been raised today, that Ms. Smith has said in particular.
Sorry, are you suggesting that in addition to what I've proposed to the Care Board, that we as a committee set up a task and finish group?
Something, yeah, in that area.
Of that, do you wish to propose that?
Yeah.
Right. Would you have a seconder for that? Councillor Medland. So I've got two proposals. One proposal that hopefully you captured, Melanie, of putting our message to the ICB saying that we want it on the agenda and that this committee says it's a priority. And then a second proposal for this committee to set up a task and finish group.
Michelle.
Yeah. So what would be the best way forward from your perspective as chair of the ICB?
Thank you, Chair. Firstly, I just wanted to say it is on our agenda and has been on our agenda regularly. It is also on the agenda of the Isle of Wight Quality Meeting as well, which Joe attends. I think we will make sure that it's a rolling agenda item. As far as I know, it is. So please be reassured this is already on our agenda. I mean, there's also something about maybe bringing it to the Health and Wellbeing Board so that it's widely spoken about, particularly from other perspectives. So that would be a suggestion. So please be assured it's already on the agenda.
Perhaps from your suggestion, is that we make sure it does go to the Health and Wellbeing Board and is actually seen as a major health issue with other health issues.
I think particularly the health and well-being, because that's particularly with if you've got bad teeth, and all the ramifications of bad teeth really affects your well-being. So it'd be something, I mean, the more we promote this, the more we talk about it, the more it's on people's agendas. I think we need to put it to as many places as possible, would be my suggestion.
Thank you, Chair. Just a very practical point. I agree with the approach. Can we just try and coordinate action so we're only doing things once, not 3 or 4 different times in different places? Just make a plea to the committee that we do it so we get the best focus and the best outcome.
I think, I mean, if we as a committee set up a task and finish group, at least we are looking at, because that will be consulting others, like, you know, we do it in partnership normally with Health iWatch. But I think I get the feeling from Councillor Drew and other members that we want to take some responsibility as a committee, as elected representatives, that we do not want this to just go away. We want to actually actively work with you in finding a solution to the question is, when do we actually have the, you know, a situation where all islanders have access to NHS dentistry, children have proper care and help with their teeth, which happen. So I get your point, but we just want to keep
sorry,
it.
forgive me, Chair. It wasn't about a criticism of different actions and different, it was just about how we can coordinate all of our thoughts into a single action plan to get the results that you're after. So that was it. We can do that outside the meeting, and perhaps 2 or 3 of us can just have a conversation about how we might do that best.
Simon, you wanted to come in?
Yeah, so just listening to the conversation, recognising this is a really important issue. Simon, Cooper and I have met to talk about these things. I think this committee is about scrutiny. My suggestion is, as Darren said, let's take it outside. Simon has, I think, said he'd come back next time to show an update. And then I think we need to work out what the actions we want to take as a scrutiny panel, which bits we need to scrutinise further, recognising that Simon said it's going to take a long time. And we need the regular reports at this board, at this committee, to understand the progress being made, working, as Michelle said, this is an issue around, you know, it's not just about access to dentistry, it's about the well-being. So let's, as officers of various organisations, get together, but bring a really comprehensive kind of 360 report on the whole issue with Simon's input next time. And then I think it might be, then the committee can work out what it wants to do, because the committee is about scrutinising.
Okay, I suggest that our proposal is slightly adjusted, that we have a meeting with the key stakeholders and relevant in the near future to actually decide a agreed way forward. Is that, yeah? Can I have a seconder for that? Yeah, do we agree that as a proposal?
Yeah.
Okay, thank you. I think it's a way forward. And thank you for all the contribution in that, because I think it's an important subject. If we go on to Sarah, we changed the agenda slightly to make sure that you were here. So I'm now going to actually go back to item 7, which is update on patient transport. What I'm proposing is we've actually got Paula Brislington to actually come along and actually talk about her experience and the experience of other patient users within that. And then we've also got Joanna, who's done sort of some work on this as well. And then it's an opportunity for you to speak on what has worked on the users group. Okay, so are you ready, Paula, to speak? We're all waiting.
As I ever will be.
Mm.
Right, this is about my partner who 4 years ago suffered chronic kidney failure, complete kidney failure, plus liver failure. But the liver's under control, but the kidney cannot be under control, so he's on dialysis. I won't go into great detail, but it's home dialysis, and he has to do it 4 times a day. But he's under Portsmouth, and he's under Dr. Sampson at Portsmouth, and to have his treatment, he does it 4 times a day, but obviously he has to travel to the mainland a lot for other things. He has to have scans, he has to have dye put in his neck and all this sort of thing. And obviously this takes a whole day, and he's a very, very, very poorly man, but he's only in his 60s, but he cannot get better. He's not well enough to go on the transplant list. So he's actually with this condition for the rest of his years. And I just try and look after him the best I can. Some appointments take a lot longer than you would think. If the appointment is at about 10 o'clock, 11 o'clock, they understand that we're on the island. So they do make the appointments around about 11 o'clock onwards. Because we go over on the fast cat, and then we get the bus from Portsmouth Hard up to QA Fareham. And that takes an hour in itself, but that isn't the issue here. He suffers a lot on the ferries with anxiety because of his condition. All I can say, I won't go into detail, but if you Google peritoneal dialysis, you'll see exactly what he has to go through. And it really isn't nice. No, I wouldn't like to do it. The reason that he is on peritoneal dialysis and not hemodialysis is because the dialysis unit on the Isle of Wight is very small, and they are recommending that most patients who now are diagnosed with kidney failure are put onto peritoneal dialysis on the Isle of Wight because it's easier for everybody, including the patient. But with Whitelink, it's been very, very difficult. He feels very aware of his condition, and on the odd occasion we've gone over by car, he has to get out the car and go into the lounge. You know, he's not allowed to sit in the car. And several times he's had surgery over there because he's got an opened catheter which comes out of his peritoneum, which is an open wound. He's had sepsis 3 times in 4 years, very, very badly, and he's been hospitalised more times than I can tell you off the top of my head. So it's been difficult. When it's really severe, he is taken by ambulance. And in March, he had a very bad relapse. He couldn't eat for something like 6 weeks. When eventually I called 111, he was taken within half an hour of the ambulance coming to St Mary's, but they couldn't do anything about him there. They couldn't give him his dialysis because they haven't got facilities for peritoneal dialysis, and they couldn't get an ambulance booked on the ferry to get him over to QA. So he was in a corridor in St Mary's, but he actually said they were really nice there. They did all they could. So I'm not complaining about any staff whatsoever, even Whitelink. They are lovely. The staff are lovely. It's the organisation which hasn't got any compassion at all. And eventually they got an ambulance after 2 days. And of course, he was very, very weak because not only did he have sepsis, but he also had a severe malnutrition to not being able to eat. And he hadn't dialyzed for 2 days, so he was very weak. He got over to QA, and I didn't go and see him for a fortnight because he had sepsis and he was in isolation. They managed to get him under control, and right. He was in hospital for 12 weeks, and then eventually sent home to Highfield Nursing Home by ambulance. Again, there was a 2-day delay between him being discharged and sent home because they couldn't get an ambulance onto the ferry. So that wasn't good again. When he had his catheter in his peritoneum inserted 4 years ago, we were rushed out of hospital because it was the day before lockdown. It was the 23rd of March. He was diagnosed on 30th January. Lockdown started on the 24th of March. And he had his operation on the 22nd of March. So the next day I had to come out. I don't drive. I had to get him for an open wound into a taxi to the fast cat. I had to get a wheelchair, and the fast cat wasn't running very regular because they were getting ready to close down. Again, the staff were great. They helped me. And eventually we got him over to Portsmouth, and it was just horrendous. That's my experience. The other thing is the fares are astronomical when you've got to travel backwards and forwards. And I know 3 people that have had chemotherapy and radiotherapy in the last year. And if you're not in any form of benefit, you don't get any help whatsoever. All you get is a little bit of discount from Whitelink. I can't talk about Red Funnel because we don't use them. We only use Whitelink because he's at Southampton, he's at Portsmouth. So he, it's astronomical. A couple of times he went by car, but it was just not possible. It wasn't viable to go by car because of the cost, even though it was a lot easier for him, but he still drives. So we knocked that on the head and we just use the public, you know, for passengers now. When he was in for those weeks, it cost me, even with a senior citizens discount, it was £16.80 every week I went over to see him, which adds up. It was well over £100 at the end of the day, just on going to see him, and that's without all the extras, you know, like doing his laundry and all that, which is nothing to do with that. But anyway, so it was a lot. I used to go once a week. Getting back to Whitelink, they really need somewhere on the ferry for sick people. They need a separate area where sick people can go. There is a quiet zone. It's right at the top, which actually defeats the object if you can't walk. I know there's a lift, but it's a real, you've got to get out, you've got to wait for the lift, you've got other people buzzing around you, you've got to get up there, and if you get a coffee, you've got to take it up there and back. And we're both in our late 60s. I'm 17, a couple of months' time actually. And it's all getting too much. And this Whitelink business is actually adding stress onto other stress. It's just building up stress. The money side of it, which people on the mainland, they just get in their car and they drive to the hospital, or if they're pensioners, they got their bus passes to get to the hospital. Don't understand. It's not just the fares, it's all the waiting for the ferry, and then they move the ferries, they move the times. And we've actually been at the hospital and he's had treatment and he has to leave because the last ferry, this was in the winter, was at 8:20 at night. They stopped the fast cats. And there was no way I could get him round to the boat, the big ferry, because the man couldn't walk. So it was awful. They were great at QA. They completely understood, and several times they kept him in overnight because it was the only way around it. But then, of course, our ticket wasn't valid, and we had to buy another ticket. You know, so it's like you're fighting to stay alive, but you're also fighting to stay alive in another way, you know, because they just can't seem to realise. And, you know, you get on there and you're ill, you've just had surgery and you sit in a chair and you've got kids bumping on your seat, you've got lads, okay, lads are lads, but this is an actual incident, who were shouting across us. And Chris has had a general anaesthetic only the day before. And it was just horrendous. And there was nothing Whitelink could do about it, nothing the staff could do about it. But Whitelink really need on the CAT a separate area, even if there's only half a dozen seats, for people. And I can speak on behalf of my friend and his wife, who's unfortunately just died, who had to travel for chemotherapy. And they were just, it was horrendous. Coming out of having chemotherapy and then having to get that boat back home. Couldn't stay overnight because it was only once a week, it wasn't every day. But that's just another example, but that's not my issue. Chris can't get better. We've got this for the rest of his life. You know, it's not a case of going over there, oh, it'll be right in a year's time. It won't. He can't get better. He's got no kidneys. Kidneys don't reproduce, they die, they're dead. He can't go on the transplant list. He's too poorly. So this is it forever, for the rest of his life. And Whitelink, there needs to be accessible toilets, a quiet zone with accessible toilets where people that have had serious treatment, a lot of medication, invasive surgery, can sit quietly and just relax and be comfortable. And the most thing that I know they feel, and I feel to a degree as well, because I am his carer, is anxiety. I'm getting anxious now, and it's not talking to you, it's just knowing the situation. It's really, really bad. And you've got the travelling and you've got the lack of compassion. There's no compassion. They just move a ferry, you get there and it's stopped. And what do you do now? You know, he's not well enough to go and have beer and wait. You know, the man's can hardly walk. So anyway, that's why I'm here. I'm representing the White News Group in that capacity, fairs and invalids, people who really are ill, who've got no choice but to travel to the mainland because the island hasn't got a peritoneal dialysis department.
Thank you so much. I think it's been incredible, incredibly moving. And thank you for your bravery and courage for actually making that testimony to, you know, 'cause it is a testimony to this committee, and it's recorded within that. Can I first go to Joe to, if there's anything you want to add to that, because obviously it's side, and then I put to, well, other committee members, no, put to yourself, Councillor Modsdale as well. And then perhaps we can then come back to you, Darren, with the user group. And thank you very, very much. Joe.
Thank you. I think that says it all really, and I think you speak for a lot of people on the islands. And you said it so eloquently, and you really did. There's nothing more powerful than someone's experience, and your description of how you feel as a carer, on top of, you know, how he feels as well. It's just so powerful, and it's so important that people realise the impacts that small piece of water has on people, and the fact that we are different to living on the mainland, and the effect on your mental health as well, the anxiety. Yeah. Yeah, so again, I'd like to thank you, and as I said, because you are speaking for a lot of people, and yeah, there's nothing more I can add really.
Councillor Modsdale.
Thank you. Most people know that I've banged on about this ever since I was elected, and I read the report with some concern. So I have a few things to say about the report. Ferry companies offering discounts on the prices that are charged aren't worth anything really. If you're having a 10% discount on a journey for health travel, but actually it's in the height of summer and your journey would be £300, 30 quid off that really isn't a lot to actually have as a discount. There needs to be a set amount of money agreed as a reasonable amount that we can ask for travel for those who can afford to travel. So for example, if Red Funnel charged a set blank £60 for a return of journey, it wouldn't matter if it was the festival weekend, it wouldn't matter if it was the middle of the summer. To me, that would be a lot fairer than a discount on something when the ferry prices, as we know, charge an obscene amount of money and hold us all to ransom. My real concern about the report is on page 30. I'm working off a laptop because I don't agree with all this paper you all print out. I will save the planet personally at this rate. And it comes to the last paragraph that says funding. Now, I've been part of more committees and task force than anything you can imagine over the last 6 years on patient travel. And I can say there was a big report done on funding for patient travel. And to fund it properly, you are talking about £900,000 a year was the first estimate that the groups had come out. And there was a report done by, I think her name was Caroline, who worked for the Clinical Commissioning Group, who's now the ICB, that was the sort of figure we're looking at. It's quite misleading, this paragraph that says funding for patients to travel to the mainland has historically been provided by the Isle of Wight Council in a way of a grant to the Isle of Wight NHS Trust. That is not true. So there was £60,000 that was ring-fenced for cancer travel. It was very hard to access and there was lots of criteria it had to be fulfilled before that money was handed over. If anybody thinks that £60,000 was going to solve any of all our health travels, they're very much mistaken. This is really, really misleading. And then for it to be reduced to £30,000 and then withdrawn because actually the money wasn't used. The money wasn't used because it was so complicated for the different criteria for that to be used. So actually that funding's disappeared from the council going to the NHS because it was really hard to administer and it was really hard to prove how that money had been spent. So actually, when it comes to funding, I would like that whole paragraph deleted off this report and then reported back to this committee, a corrected report with the true figures that should be in there for what health travel should be. And I think if we start about 900,000 and look a bit more, we might be looking at the bigger picture. You know, this has been discussed with MPs. It's like the subject that never gets a decent answer or solution. You know, I know Joanna feels as frustrated as I do, that how long do we discuss something, especially when we're talking about more services going to the mainland or more shared services. There is that whole thing of times and conversations with ferry companies, etc., making the journey more comfortable, but people actually need to be able to afford to make the journey, know that it's going to be reasonably means tested. So actually, if you have a diagnosis and you have to travel on a regular basis, you don't end up feeling you're using your life savings just to have a treatment that if you lived on the mainland would be equitable across whether you could financially afford it or not. So I'd really like to see this report corrected and come back to this committee without saying it's the Isle of Wight Council that did that funding, because actually that was an inoperable system of funding and it doesn't really give the real picture of what this should. If you lived on the Scilly Isles, you would be in a completely different situation than you are if you're a resident on the Isle of Wight. And yes, I do feel very strongly about this, but everybody knows that. So I've been talking about it for 6 years and I'd like to see us at least get it right. But discounts are no good for anybody. Thank you.
Thank you, Claire, for giving that, and I also thank you for your consistency over the years on this issue. Darren, I hand to you on that report, right? And then I'll open up and let me for other members if they've got other questions.
Thank you. Firstly, thank you for what you said and how you said it. Passion that you showed, despite all the frustrations and the anger, concern that you family have. So thank you for that. Sorry for sitting back. The issue is a long-standing one. We know that. We know that. We have, as far as I've been here, had several attempts at trying to solve this. Never quite got there. I took a decision in the early part of this calendar year to stand up and say, I want to sort this out, which is why I volunteered to chair the committee that we've set up as part of the Island Health and Care Partnership, because it's that important an issue to our population, our communities, our people. So that's the reason for doing it. Whatever I say now is wholly inadequate in response to the challenges that you've informed us about, you've told us about. It brings it to life, doesn't it? It absolutely brings it to life. And Joe, your report is not the first report that outlines that, and it won't be the last, let's be honest, because this is another, it's not another dentistry, but it's one that's going to take some time to work through, to solve and to resolve. So whatever I say is going to be inappropriate or inadequate, certainly. We have made some progress, though, in that, as outlined in the report, we've got a multi-agency task force set up as a subset of the partnership on the island. And we talked about it at the last meeting, actually, Joe, which you were present at. And we said that we needed to have a standing agenda item to resolve this. So from a scrutiny perspective, Chair, you've got some assurance again through Michelle and others on this committee that that is alive and will be a very live agenda item. Progress that we've made so far, again, just seems a bit sort of trite to say what we've done so far, but we have made some progress. We've got now a commitment from each of the 3 ferry operators to at least sit in the same room with representatives of Health Watch, patient groups, various different statutory organisations, and as many other people as we wish to bring to that table, which is, as far as I'm aware, the first time we've been able to do that. So we have well, maybe as far as I'm aware, Councillor Monsdale, but others may have different views, of course. So we have an opportunity, and the paper in paragraph 7 asks for all of the things that people have said today, which is, what are the things that we'd like? What are the things that we want? What do our population need? So if we gather all of those through a mechanism, we've got an opportunity to start to make some progress to address some of these things. There's going to be a bit of relationship test. There's going to be a lot of commercial aspect to this, and the funding, though the paper is actually factually accurate, it doesn't talk about the whole cost of travelling to the mainland for care, which is your wider point, Councillor Monsdale. Indeed. Agreed. Yeah. So we can work that through. So a commitment here, some progress made so far in a few months that we've been running, more progress to make, and the partnership board will be the way that we will see further progress made. And I'm incredibly grateful for all the comments this evening and over the next few weeks and months for people to feed in thoughts, ideas and improvements, so we can raise those with the operators and then have a formal accountability programme to ensure those improvements are made.
Thank you, Councillor. Sorry, Councillor. Nearly promoted you there, Michelle.
Thank you. One day, maybe. Thank you very much. Just to assure the committee that we definitely have that as a priority on the Health and Care Partnership group, and we will have it part of the role of that Health and Care Partnership is to, in a way, scrutinise and make sure we hold people to account for delivery. So we'll definitely be holding to account my colleague Darren, but please be assured that it is a priority for us. Thank you.
Councillor Midlands and then Councillor Robertson.
Want me first? Yeah. Just a quick comment. You asked in point 7. No, sorry. Yes, point 7. If we have any suggestions for your agenda, I'm really pleased that you've set up this task force. I think it's extremely the improvement board. I think it's extremely useful, and you've made some really good progress so far in at least establishing some of these kind of broad areas and getting some broad understanding. What I think I would like you to add to your agenda is the cost of accommodation for both patients and visitors to patients, because this is a massive financial burden on people. And is there any way we could find for people to be able to stay in Portsmouth and Southampton overnight that's not at a commercial rate? I don't. Maybe that's some arrangement with the local health provider. I don't know, but it's just something I think I'd like you to look at it if there is a subject. And the other thing brought up in the Health Watch paper is the situation where people are leaving St Mary's in the middle of the night and they have to get a taxi home. And I live in Freshwater, and you can imagine, you're talking, well, if you can get a taxi, be very lucky, but the cost would be absolutely extraordinary. And again, it's the same thing, very, very high transport costs. So I'd just like to just mention that again, because I think that was a very good point in your point. Can the NHS be a little bit more careful about dismissing people at 2 o'clock in the morning from some areas? Thank you.
Chair, on the matter of Whitelink and the ferry companies, I wonder if there's an opportunity here for the committee to write to the ferry companies, raising directly some of the concerns that we've heard today, particularly on pricing and on facilities or lack of facilities for those crossing the Solent, and to make that letter specific, ask for a specific response to some of those concerns. I just feel if it came from this committee of the council, that would add weight to the campaigns and the issues that private residents have been dealing with on their own for so long.
No, I think I welcome that. Is that a proposal?
I'm very happy to make it a proposal.
Can I have a seconder to that? That this committee writes formally to Whitelink from this meeting and from your testimony to actually raise those issues. And perhaps Joanna, you would help with that letter from information. I've got a proposer and seconder. Sorry.
Can I just say probably all ferry companies, all private. Well, they are private, yeah, ferry companies.
And second,
Chairman,
can I have a show? Sorry.
would it be useful before we send that letter just to run it past Darren as he's chairing that
Yeah.
transport committee to make sure it's toned right?
I would welcome that amendment to the proposal. Thank you, councillor.
Sorry, thank you. Thank you, Paula, for coming. It's been really helpful, and we'll keep in touch, and we'll also communicate this letter so that you regarding that. Thank you very much. I'm going to suggest have a 5-minute break so that we will have water and side, and then so if we can come back. Huh? If we can come back at 5 to 7, that would be really good. Thank you. Right.
Yes.
Yes.
Just look out now, so it's not to disturb.
Is that okay? We
Yeah,
still quorum though?
Yeah,
Yeah, we got 3. Yeah, we are quorum. Yeah, no problem.
Okay, all right. That's right. Would you be able to circulate the draft letter to the committee members just to?
Yes, yeah,
Is
I
that
can
all right?
do. Yeah, I can do. Well, I'll do it collectively.
Yeah, fine.
Yeah, fine.
Yeah.
Yes, it's quite handy having a couple of solicitors on.
Yeah. Right, can we come and start back? Thank you. The next item now is item 9, which is the update on dementia strategy. I've spoken to Maggie Bennett and Mark, and we've sort of felt that you've got the pack of the and the various information in the pack. So we're going to actually not show on the screen. We're actually I'm going to ask Maggie to present the report or the voices, and particularly raise the issues that actual service users or people using a service and their families feel about. So over to you, Maggie.
This works. Is that right?
Yes.
Can everybody
Yeah.
hear me now? Hi. Well, thanks for inviting me, Michael. I'm delighted to be here and to praise this report as it stood. So has everybody seen the whole thing? They've had the opportunity to see it. Okay, great. So I've highlighted a few areas here, and I think picking up on some of the themes that have come through this evening's meeting right the way from the beginning is this issue around communication. If there's one thing that people who come to the cafes, people come to Carers Isle of Wight say, it's about please can we have clear communications. Please, people who know me, I've just said to my colleagues, know that I hate the pathway word. I'm really anti people being put into a box before anybody's even met them. So there's lots of bits and pieces here. And again, I can praise this very quickly. Issues like people dealing with complex medication, people beginning to live with and support people whose behaviour is different, and it's going to look very different. And I was saying in the cafes, one of the things we talk about is this mal issue where people with dementia suffer from difficulties with memory, attention, logical thinking. Once you get that right, you can understand where they are, and they are all different and all in a different place and a different time. Some people have moved along in that journey much further than others before they come to the attention of services. So it's wrong for them to start at the very beginning. And one of the issues that was here was that we asked the Admiral nurse for help. The memory service said they'd been discharged from the memory service and that I should contact our GP. And the GP says, we don't deal with medication for dementia sufferers. Now, I know from Michelle's work, Michelle's always been a huge supporter of all of the work we've done around dementia. And I remember being summoned to her practice many years ago to say, why should I be diagnosing these people early on? And we had a full and frank discussion, didn't we? And it's about saying, people are confused. They feel that when they go to their GP, they'll get a response, instead of which they're going to the memory service and waiting a year for that, for someone to diagnose whether they've got dementia or not. Now, I know that colleagues are working really hard on that, and it's similar to some of the issues that have come up. It's around workforce, it's around trying to bring people to the island. There are huge issues, but nevertheless, the voice of our people here is that I have no diagnosis. My access to other services is therefore limited. My access to benefits like a blue badge, like council tax refunds, like all of those issues are sorely limited. And I'm responsible. Carers are so distressed by this process of not feeling listened to, of being scrubbed off of a list You don't need me for the moment. I've done the bit that I need to do. I've followed the pathway, and now you're not, we don't need to provide any more services for you. One of the issues here I found was so distressing was the bit about cluster, that eventually I was informed we would not be suitable for the course. We were informed he was cluster 19. Now, to anyone who has no idea what cluster 19 is, there are many clusters, and it's all about the level and where you are in this journey. At the Alzheimer Cafes, we describe it very much more simply than that, and talk about how people move through this journey, and how things change for them, and cognitively how things deteriorate. So being told that you are in the box of cluster 19 is not helpful at all. You've no idea what that means or where that's going. There's been some good news. The dementia outreach team were mentioned in some of this as being exemplary. They worked really hard. They were responsive and effective. They went out and they supported people. But the message generally is, I have to tell my story so many times. Actually, with dementia, as those of us who work with people with dementia know, that changes week by week by week. So to tell the story that I told 2 weeks ago is going to be very different than the story I've got today. So we need a real understanding of what that looks like. And I think certainly the work that we're all trying to do within the dementia implementation work around the strategy is taking all of that into effect. Certainly there's lovely comments about the charities that are involved. Carers Isle of Wight do a training program. Of course, at the Alzheimer Cafes, that's what we do too. And people just want to come and talk. And one of the biggest issues for me, and I think something that could help, the cafes were designed originally way back in '97 as a location that's safe, that people can come to and meet professionals there. And because of all the issues we've had, one thing and another for many years, and I know Claire knows all about this, I've nagged her about it for years, that we'd like to see those professionals back at the cafe, so that, when people come along and they want to talk to somebody. When Michelle came to do the talk at Ride Cafe the other week, she was like a celebrity. People came from island wide because Dr. Legg was going to be there talking about what is dementia and what isn't it. And I say that not because she's sitting here, but I would have told you anyway, even if she wasn't, because that's testimony to what people want. They want information, and they want it real, and they want it in real time, and they want to believe that that is going to continue through the system. So, that's where people are coming from. And I know you've had the opportunity to listen to that voice, and hopefully you've been able to pick that up from the reports. And certainly I don't feel that I need to say any more than that, apart from people are out there feeling alone and hugely confused. And confusion, obviously, we know is one of the biggest issues for people with dementia to manage in the first place, but their carers who don't sleep at night because their cared for person only sleeps in snatches of an hour at a time. Dealing with incontinence. I had a lady came into the cafe and she said, what am I going to do? My husband's going to have to go into a care home because, he's incontinent during the night, and I'm 85 and I can't manage the laundry. So I went to her the next day, stole stuff out the cupboards at work, went to her with all this batch of stuff, and she said, with that, I can manage for another year. That's simple, that works, and that's what we need to be able to do, is provide those really simple opportunities to help people. And the stuff we've talked about for funding and all the rest of it, how can we tempt these people to come? How can I, in my new hub that's going to be all singing or dancing, and hopefully you'll invite me to talk about that later, can I have a professional person there who's going to help with this? And have we got something where we can triage and do something as an interim measure to say, do you know what, we're pretty sure that this is what's happening. We haven't got the formal diagnosis. Can you live with that for now until we can get to something? And I think people would respond so much better with something like that. I went for a meeting with Sally Grills today, and she's so excited. She wants to work very much with us. As you know, she's very involved with everything. But of course, it is about those people who speak to her and speak to everybody everyone else about, please, can we get this right? So that's what I'm here for. If you've got any questions, I'm very willing to take them. The Isle of Wight Council have funded a training programme. The trusts have got a great training programme in place now, all working with the same ethos and learning, and it's starting to pick up and go really well. But again, you know, it's hard going, but we're getting there. So my mission's always been to educate the whole of the Isle of Wight about how to work with people with dementia, and we sort of feel we're getting there. So thank you.
Thank you. I've got a couple of questions that I would like to ask. You talked about poor communication. What do you suggest that we, when I say we, collectively the island, all the stakeholders, actually do to improve that?
Well, one of the issues that came up right at the beginning when we first talking about the strategy, Carers Isle of Wight, particularly because of the way they're set up, offered at the beginning to do a service where people were referred, once they were referred, say from the GP through to the memory service, that they would pick them up with the person's permission, of course, and with their permission to share their contact details, but they would pick them up at that stage for preliminary support. Right, come to the Alzheimer cafes for this, come to Isle of Wight Carers for this, come to some training for that, and hold them. A similar, it's called the Carpe Diem, it's works in the Netherlands and works very similarly to that people are held and people give them a call every 2 or 3 months. Hiya, how are you? How things are going? You know, how things going? Can we support you in any way? Is there anything more you need? Lots of people say, no, I'm okay for now. But actually, the thought that somebody's there in the background and still holding on to that is something that maybe could be considered. Obviously, I can't speak for carers. Lizzie's not here, but that would be a workforce issue for her. But I feel sure that it's something that could be achieved relatively cost effectively. And also when our new facilities open, that we can truly be sending people, and that hub knows everything about everything that's happening around dementia on the Isle of Wight. A little service that's just started happening in the West Wight. Four carers have got together and they're cared for, are all in one space. They all go to different house each week, and one of the carers gets the day off, and so that carer goes off, and that's been organised by them themselves because they've seen how helpful and valuable that is. And I'm hoping that our Alzheimer Cafe Daily is going to be a real respite opportunity for people, because there'll be an opportunity for people to be with us from sort of 9 in the morning till 4 or 5 at night. So, and in a very sociable context where loads of other people are coming in to support us. So, yeah. So there's many ways we can do it. I'm conscious that health and social care can't do it all on their own. They can't. We as a collective need to understand. Our community needs to understand what it's like to live with dementia and to care for somebody with dementia, and they need to come out there. And counsellors, I think you had some dates for coming to a training session that I was offered, and so far I haven't got anybody on my list. So I find that quite disappointing, and it would be really helpful if some of you came along and understood it a bit better.
I take that on board. I will, if we can make a note of writing to councillors about the training, including myself. Sure of that. Can I just ask one more question for me? And I know Councillor Mosdale wanted to ask a question and others. In the strategy, it might be for you, Mark, as well, the strategy comes to a sort of dates, you know, is it up to like 2025?
Yeah.
Right?
Yeah.
Well, we're heading towards 2025. What's the vision up to 2030? I just feel that perhaps we need to be looking now for how the strategy is actually extended, right?
Yeah.
To 2030.
Well,
and I just wondered what your view of that.
My own view is that we've been aware of these numbers and the prevalence of dementia here on the island for a long time. And I've got a slide that I actually put in a presentation in 2012, where our JSNA had actually predicted exactly what the numbers are now. So that was phenomenal and really good planning. And I think if we listen to what this data is telling us, and the data is very clear that by 2030 we're going to have, it says about 4,000, well actually it's going to be nearer 5, because we all know that there are a number of people who aren't actually diagnosed, and I'm sure Michelle would back me up on that, and we've got a big list at the moment who certainly aren't. So that's the work we need to do. And if you look at the co-production report that came with the dementia strategy, and by the way, it was real co-production. This wasn't something that we went out with an agenda at all. We went out and we gave people the opportunity to really tell us what they needed. And that co-production report, from my point of view, is an absolutely stunning piece of work. And we have to really thank Jess Entwistle and Kathy Glover of the Isle of Wight Council who put that together, and it's genius. I've reread it only the last week or so, and it really is hugely powerful and links with this to tell the story of where people truly are. And that's what this has got to do. And I'm sure they're going to tell you, you know, how far they've got. And it's, the issue is we cannot ignore this. We have to be a dementia friendly island. We have to get this right. And we have to be able to talk openly about it in a very transparent way. We have to understand that people are living with this every single day, and to be the carer of someone who has dementia is the biggest challenge that any one of us will ever face. And when you've lived with that, and you know, we know the difficulties around ongoing care. We know that, you know, our care homes are stretched pretty much at the moment already. There are few of them who can take people with the most complex needs. And so, you know, all of that, the education programme is vital. And I'd thank the Isle of Wight Council, who were very foresighted in providing that support, and actually the trust, because they've spent a lot of money to get their programme going. So that was just brilliant. And we, you know, I keep saying every young carer I come to, and I'm teaching from 18 onwards, and I'm saying, you know, you're the one. I'm gone. I'm out of here. You know, by the time we need this, you are some of the most important people on this planet, because you're going to know how to deal with this. And the skills they need are not to a penny. It's massive, the skill shortage that we have in really understanding this. And of course, resource is another issue, and I won't go there, but you know, it is about people understanding what this is doing to people. And if we're to keep people at home as long as possible, I'm doing some work in a week or so's time around falls. And so one of the things we've got going at the new facility is going to be a gym where people can focus on strength and balance, but they can do it with a bit of a laugh and joke and not be there with the 25-year-old and who's doing this with his muscles. So it's going to be great. And, you know, hopefully we'll get some good research out of that, and again, be able to keep people at home for longer, because, you know, the more we can do, the better it's going to be.
Thank you very much. Before I bring you in, Councillor Mustard, in a sense, if you wish to add or within this, but I put the question to you. It seems sensible that we know from the information provided that in 2030 you're going to have this huge increase. Shouldn't we be gearing up the strategy to that reality?
Shall I start? I'm sure Jess will want to come in as well, Mark, maybe as well. So I think from a health perspective, we've had a mountain to climb here. And some of the work that's happened in the last few years has been phenomenal. And exactly as Maggie says, the fact that Maggie is working in a programme that Michelle is involved in, that Trust Services, that Mark's services are involved in, we're actually properly collaborating on a plan that will get us where we need to be. But it's, my view is when you're utterly transforming services, which is what you need to do, you need to keep an end point in sight so that you can achieve something and then move on to the next thing. And that's part of what we need to do here. from a purely health perspective, you'll have seen in the slides a particular focus on the memory service and the waits for a diagnosis, and on dementia beds. And the memory service, I guess to take a step back, a few years ago, the only mental health services we had for people with dementia were a memory service providing diagnosis and beds. I won't use the P word, but in the opposite ends of the pole. And actually, the response to Maggie not wanting a pathway, I agree, is about being able to offer person-centered care that meets people where they are. And they're not all, obviously, at a point of needing a diagnosis or needing a mental health admission. There's a massive yawning gap between the two. And so we've been working really hard to fill that gap with partners, working across so that we've got a whole island solution. The Dementia Outreach team is a really good example of that. And it's a good example of how you can take existing resource and repurpose it. We didn't have any additional investment in Dementia Outreach. We took the money that had gone into the ward in Shackleton Ward and spent a small amount of it, unfortunately, on having to send people over to the mainland for beds. But many, many fewer needed to go into a bed because we were able to put support into community, supporting people at home through the Dementia Outreach team. And that, it was cost neutral over that change in service. There's a lot more we need to do. It'll undoubtedly need investment. And one of the real areas of focus for us from a diagnostic perspective is I think we had a very old-fashioned approach. It was utterly dependent on consultant psychiatrists who are rare as hen's teeth. And so we actually had a point not that long ago where we had no substantive older people's psychiatrists on the island at all. And the impact of that kind of vulnerability in our system is really significant. So we now have trainee nurse consultant, advanced nurse practitioners. We're really diversifying the workforce, which is entirely in line with the way other services on the mainland changed probably a decade ago, quite a long time ago. So we're catching up in a way that provides us with greater capacity, greater resilience, and allows us to start to catch up with diagnosis. But there's still a huge way to go because we're increasing that capacity at the same time as demand is increasing, and as you say, even further down the line. There's no question there'll need to be more resource. There's a limit to how much efficiency we can drive out of existing resource, although we're doing a pretty good job of that. And then the final bit is about the beds. And I know I've talked here about the beds many times, and I know there are a number of new members of the committee who may not have been here for some of that that kind of journey around our mental health inpatient services. We closed our mental health inpatient ward in 2019 because of quality and safety concerns. And as I said, small numbers are now needing to go to the mainland. We have found, we think, a solution to that, which is a new model of care in 7 Acres, which is our mental health inpatient unit on Afton Ward. We're piloting it because there are some real challenges in delivering dementia care alongside mainstream mental health care. And it's a different skill set. Exactly as Maggie says, you need very skilled staff. You need a different environment. We've had to reduce the number of beds, so we've got more physical space for people. We really need to test the impact of having a ward that has both older people with mental health problems and people with dementia in the same space with the same team. That pilot is around midpoint at the moment. We're doing a midpoint evaluation so that we can tweak it. We've got a number of partners involved in that evaluation, and as that's completed, as the pilot is completed, we would really like to come back here and share the outputs of that pilot with Overview and Scrutiny, because we think that will give us the long-term, I'm hoping, the long-term solution to mental health dementia beds for the island.
Because mental health is on the agenda, the next meeting, perhaps we could in December have an update.
Yeah, we'll definitely we'll have the midpoint evaluation outcome then. We won't have I don't think the pilot will have quite concluded but we'll certainly be able to update. We'll have a good indication then.
Okay,
Yeah.
thank you. Councillor Mosdell.
Thank you. It's two statements really, or sort of a question. So the first is, it's really sad, isn't it, that we're in a situation that whatever political colour pants you wear, whether they're yellow, blue, green, red, there is no long-term. We talk about, you know, what's going to happen in 2030, but actually in my time, I've seen so many changes to white papers and Mark's in agreement there. You know, how many white papers have we seen on the future funding of adult social care? And I have to congratulate people like Maggie, who not only gets a pint out of a pint pot, she gets 3 pints out of a pint pot, you know, and manages to manage that very limited funding. We also have to highlight the disparity that if you sadly your relative had cancer, you'd be in a very different financial position and level of care as if your family have got dementia. And the other thing is, I've got to an age that most of my friends now are dealing with a relative who has dementia. And I'm probably very lucky that for 4 years I did quite a responsible role, but worked very closely with people like Maggie. And I can say that a few of my friends I've been able to direct to Maggie's services. I'm not saying go use Maggie, but there's lots of things that you need to do. But I think actually what we should do, I'm very concerned sat here listening that Maggie's offering something and councillors haven't taken it up. I could honestly say if it had come into my inbox, I would have signed up by now. But clearly, we talk about communication this evening. That hasn't been communicated properly if there isn't the sign up we need. Because I know I have friends who are dealing with red lines. We go out and have walks and stuff like that and say, this is my red line as a carer, I don't want to cross it. And then we get a phone call going, oh my God, I've just had to cross that. Where do I go to and who do I speak to? Things, because there are things when you're dealing with people with dementia that actually you never thought you'd want to have to do for your own parent. And even worse, when your parent doesn't recognise what they have done is just as hard emotionally to cope with. So really it's well done, Maggie, it's absolutely amazing. But I think we all need to make sure as councillors we have that toolbox so we can advise residents where they can go to help, and also how we can actually complete our toolbox a little bit more on how we can help our family, our friends and our residents with it. Thank you.
Thank you. Is there any questions from the committee members? Councillor Midland. Okay. Sorry. We're okay with the quorum.
Do beg your pardon. While I'm speaking, I just wanted, before I leave, I just wanted to give my thoughts rather than questions really on this, because it's really interesting paper, and what I was sort of dealing with is, what we all have to deal with is that resources are getting smaller, but this problem is just, it's a demographic problem. It's going to get huge. It's going to get worse and worse. And it's hugely important that we're taking all these initiatives. And what I found very, I think most positive was the fact that the training efforts of staff are so productive, and I think that's given the fact we haven't got any more resources or have very few resources, how we can build up the as you say the people of the future who are going to be dealing with this problem. It is so critical. I think the education and the training aspect, and while we're talking about staff, I see them run like the officer corps of an army, that the real front line are the carers in those families who are actually taking this on 24 hours a day. And how is it we can give them more respite, more help? It's extraordinarily difficult when there's contracting resources, but it seems to be that is the key, because if they break, then everything tumbles down, doesn't it? We've got to support the people who are actually doing that hour by hour task or minute by minute task of which is psychologically so extremely wearing, and often without sleep, as was being mentioned. This to me, I think respite is crucial, and that idea of somebody phoning up every now and then, showing that there is somebody there thinking of you. This kind of thing, it has to be efficient, but it has to be I think we have to think in quite innovative ways, because obviously we're pioneering a national problem, with our statistics, which are quite scary. I think that's all I have to say. Thank you.
Thank you, Councillor Midlands. In fact, in 2012, there was a very good report done about the relationship of the carer and the carers, and it basically had a description of a seesaw, and basically the carer and the carers was this kind of balancing of that. And actually, when you really looked at it, often the carer wasn't much below the actual needs of the cared for. And it would be very good to actually get hold of that study and actually have that conversation, because I think it's important. You want to reply to that?
Just to give you a very quick story of exactly that. We supported a gentleman with dementia and his wife. He absolutely refused to come for any sort of daycare. So we thought, I'll tell you what, why don't you come too, to his wife, and we'll make sure you get a spa day. So she used to come on the day that the hairdresser came. She'd have her hair done, she'd have lunch. We used to make sure that he was doing lots of activities, and she used to get a day to relax, bring her book, sit in the conservatory and get some sunshine. The tragedy was that she died first.
Yeah. Thank you. Okay.
Just
Sorry.
briefly, really, to try and sort of summarise everything. I'm just a bit piqued with or not piqued, concerned about strategies to 2025. Realistically, looking at what we've heard today, it should be at least to 2030, because it has revenue and capital consequences for the statutory sector, the voluntary sector, across the board. And looking longer term resources and interim. I think that's the sort of thing we need to be thinking about. 2025 is not the cut-off date. It's beyond that. And at 2030, it's 50% more than what we're doing now.
I just thought it'd be helpful because I was in the discussion and the planning of pulling together the whole strategy. So when we've done a strategy for 3 years, for 2020 to 2023, I don't think there's the ambition that everything will be achieved at that point. I think the reality is things will have changed by 2023, and what our priorities will be may be different. Laura Gordian, as Director of Adult Social Care, is the exec sponsor and lead for this work. So it's obviously something we'd pick up with her, but I don't see that this strategy is going to end. What I think will happen is we will do probably another period of consultation, speak to people, see what's improved, what hasn't, and then do a refresh of the strategy. I think we're really aware that we've been very, very ambitious with that strategy. We've covered not a pathway, but lots of different stages in people's journey of dementia. And what we've really tried to do with that is focus on the areas that are probably the most important and pressing that we got out of the consultation. So that is the memory service. People are waiting too long. They're not getting the support they need. That is looking at the inpatient setting, looking at information and advice. So the setup of a hub, looking at developing and bringing in dementia navigators that we've funded for at the moment to trial out and look at having that kind of voluntary sector role that can go and give that support and go and help with individuals to know what is available in that vast gap from assessment to inpatient. And we've also looked at training. We've done quite an extensive piece of training across the patch and across all different areas. But the other bit I think that's really important that the council's been doing is work on respite. So they've been looking at reviewing their respite model and taking into consideration this as well. So I don't think we'll have achieved everything in 2023, but I don't think we can say what we will need by 2025. I think it's important that we go back and ask people, and we're going to do some great work with Healthwatch to do that, to find out what's the most important. And there were just two other things that I wanted to add, because I know this has been like a long session, but the bits that are quite important for me from the work within health as a health commissioner is there is a long wait in the memory service. We have got a recovery plan that we're working all together on. There is definitely a lot of work about increasing their capacity for assessments and support within the division. But what I would say is for those that are waiting, out of all of the services I work with, I feel it has one of the most robust waiting list management systems. They have clinical staff reviewing that waiting list, checking in on people, checking on where they are within that waiting list, looking at if they need to actually be escalated. So I think the trust in that sense has recognised that there is a big waiting list and that is impacting, and that dementia, you know, it will get worse and it will progress. And it's important that when people are on a waiting list for a year, that we're checking in with them regularly in case their situation has changed. So as much as we want to see it get better and we'll carry on that recovery journey, we are also monitoring that quality for those individuals and making sure as much as we can that they're safe. The other thing that I think is really important is I think there's been a really good change in collaborative working through this work in terms of how we work together as a team. And I think a really great example of that is when they did the Afton pilot to look at the beds on an inpatient setting, they went to the Dementia Awareness Partnership and invited Maggie Bennett and Barry Jackman, whose wife had dementia, to really review that and say, what does that space need to look like and what would work for people? And that's something we wouldn't have heard of before, I don't think. So I think we're really seeing some really innovative and progressive ways of working together through this work. But I do agree with what you say, Chris, it's absolutely got to be extended. I think we just need to know what needs to be put in there and what needs to be prioritised.
I can just say very quickly.
Very quickly,
about
because
it.
I'm going to try and wrap it up.
We started it in 2018 and we were interrupted by all the other stuff.
What happens? Thank you for that. And I think it's, I did go along to the Parklands, your event. And one of the things I observed, which I hadn't observed before, was all the different people in there. Commissioners were there talking to providers and side, and I actually hadn't seen that in particularly mental health for a very long time, if not at all, on the island. So I have to actually be a witness to that. There was that collaboration, and I think it's coming, and I think we thank that. I'm going to wrap up. Perhaps if we put a proposal that we actually welcome the progress of the strategy. We welcome that the voice listened to, and we welcome a future report about the Afrin, the replacement of the Shackleton ward. Is that, we captured that? Yeah. Can I have a seconder? Thank you. Thank you. And thank you, Maggie, for that. And please do put your thanks back to Lizzie and that towards that. So quickly go on to preparing for the winter report. If you're able to do that, Darren. And I am conscious of time, but it might be something you need to report back. Within that, is it also important that there has been a report about COVID-19 and this new strain, and the fact that COVID is increasing, and just as an observer, it seems that we have got council employees that have got COVID. I know people in the health service. So it's particularly, if it starts to really hit the whole population, it's terrible. But also, if it hits the people who are actually looking after the population, it's even worse. So I just wanted to say in your report back on preparing winter, can you also answer this sort of element of COVID? It's not probably called COVID-19 now, it's probably COVID something else.
Shall I just respond to the bit about COVID, Chair? So yes, we are seeing an increase, and the government's recommendations is that we bring forward vaccination against COVID and flu, and would really advise everybody that are in the groups to come forward for vaccination, which is the best way to try and prevent infection and the spread of infection of COVID. I think part of the learning for winter is that we have to be really flexible and nimble. We are probably expecting greater cases of COVID this winter than last winter. But last winter we had a massive, almost mini epidemic of strep A infection. and we weren't really expecting that. So any winter planning has to be reflective of what we may expect to come, but what we actually see and how we can respond to that as quickly as possible. So yes, we are preparing for COVID, and as I would just reinforce, people that are in those high risk groups and or over 65, etc., come forward for both your COVID and flu vaccine and contact your GP surgery, who will be vaccinating, I believe, from something like the 12th of September. I may not get that date quite right, so please don't quote me on that date, but yeah. But there is a date where we start vaccinating. So yeah, if that's about the COVID response, but I'll hand over to Darren for general winter preparation.
Thank you. I'm conscious it's difficult to add much to that, other than just outline that the paper talks about a process that we've got and the assurance that we should seek from that process, really, in that lessons learned from last year. But already we know that this year is going to be different from last year. So you can learn as many lessons as you like, but the scenario is different as well as those lessons. So the agility that Michelle talks about, the robustness of the plan, is what we're basing it on. The system-wide working, the togetherness in all of that is critical, because we don't want one part of the system pulling against another part, et cetera, et cetera. And the risk management that we face on the island is one that we need to just keep coming back to. We've talked about it a lot this evening, in that living on an island presents both opportunity and risk. And that risk for us over winter is that nowhere else helps when we need it. And that means our plans need to be just as robust as everybody else's, and probably more so where we face extreme pressures and extreme sensitivities. So we're testing this winter plan with a range of scenarios in terms of those sensitivities. So if this happens, what do we do? How do we respond? So that's the assurance I think we should seek from a process perspective. It's being managed by the Health and Care Partnership that Michelle chairs. So as we get into December, we'll get another report on how we're doing, given that December will mean we've already started winter. So at the next meeting, we'll get a report on where we are so far and where we're going next. The impact to our population is something that we'll need to be carefully and critically aware of, won't we, as we go through this? And I don't know whether that's through HOSC or that's a different mechanism, if that's perfectly honest, because the frequency of HOSC, this committee is one that doesn't lend itself to a. So we're going to need to find a different way, is what I'm saying. We're going to need to find a different way.
I think you've partly done what why we got it on the agenda was because last year, as you said, it really hit. There were some lessons learned. It seems that you're taking those lessons on board and are actually, implementing that. So, I mean, I think in a way it's to report back to this committee at its next meeting, just to very quickly update it so that we're aware of the thing. And I think the other particular point with the members, I'm sure we all agree that communication again, isn't it? It's actually telling people, right, out there, because they get the report from the Observer or the national newspapers that there's a new strain and it goes out, and that's when people start to panic and actually wonder of that. I mean, I think in the thing in the Observer was saying people who've gone to see the film Barbie, right, were actually quite a greater risk because they were in cinemas in very large numbers. That. They obviously don't go to the ride Condor. When I went to see Barbie, it was a smaller number, but it's that, and I think that we just need to get the information and the story out to people so that people are aware to do these things. Mark.
If I may, yeah, I'm just adding to what Darren said, really. We do have obviously robust plan in place. Adult social care through Laura participates in that, and we complementing different actions based on historically over many years the work we do in terms of winter pressure, which we're very familiar with, is what I'd say. Obviously, what we can't predict is the sort of potential crisis or issues, but what I would say as a set of services, I think we're very familiar, very able to respond to that effectively, given specifically the front line of our service where we need to ensure that workforce is operating effectively across the community. There will always be challenges every winter. There will always be different things that hit us. But my experience and observation over many years is we have the robust arrangements in place across different services to respond to that effectively, unless anybody says otherwise. Thank you.
Sorry, Darragh.
No, I would agree. Thanks for adding that, Mark. It's incredibly helpful. I think 3 last points for me. The first relates to communications one, Chair, and I know that Simon is probably still with us, but absolutely and utterly front and centre in terms of public health messaging. We need to make sure, and Simon's fully supportive and engaging with that. Hopefully his light may go on shortly. We'll wait and see. The second is we will plan to the best of our ability, but we don't know what's going to happen.
Yeah.
So therefore, that plan adaptability and flexibility and the sensitivity
Okay,
is
thank
crucial.
you.
The last thing is
I'm going to
Oppenheimer
want
was
to
busy and-
move on. Councillor Mosdell.
My point was exactly the same, that we have to remember as a council, we actually are in charge of public health. And the onus really is on Simon Byron, who I'm sure is going to be running a really good campaign on encouraging everybody to get vaccinated, both for flu and for COVID.
I'm allowed to come in. Apologies. I've had to
Councillor,
drive.
sorry, Simon, can I just say, Councillor Mosdell, contribution has been really good tonight. Perhaps you need to come back on the committee. Thank you.
Yeah,
Councillor
apologies.
Bryant.
Sorry, I had to get in the car and pick up my family. Just to say, absolutely right, we're promoting all those things. I think in the last 2 items, let's think about prevention. So let's really think about how we up our vaccination uptake in our vulnerable groups. We're doing all that work. Councillor Lilly, you'd like to get a briefing from me on the COVID variant tomorrow. It's just sitting in comms, so we can talk about that and the importance of vaccination, both that and flu. And flu in 2 to 3 year olds is really, really important, flu vac. So let's really pick up those issues. And apologies again for being in the car.
Thank you. And thank you for speaking from your car. Go on there. Okay, I'm going to move on to item 11, where we've just got basically the sort of update on service changes. We've got on yours GP surgeries in the report and pharmacies, and I've got a one extra that I will raise. If you know, we wrote to you about the dermatology and the lighthouse question, and obviously under pharmacies, the update on the position of the Argyle Street pharmacy. Sorry, Argyle Street surgery, GP surgery. We can have a little update on those things. That'd be really great.
Just briefly, I'll update on the Argyle surgery. We're happy to say that the partners have taken back their contract, and a new partnership will be taking over the contract and delivering services from Argyle.
Thank you. That is really great news. I'm sure Louise has picked that up. That would be very good news to get out to people. And can I thank you for the meetings you had in Ryde very quickly in that regard. And I'm glad we found there's a solution. So thank you. But the pharmacy.
So the community pharmacy is setting, the briefing is in the pack. Hopefully members will have had a chance to read it. This service, to some extent, change has already happened. To some extent, it relates to the 100-hour service that used to be in Sainsbury's. And it also strongly references a change in access for residents to get their own prescriptions, being online. So the paper describes the next steps in a process to gain views and thoughts from people about what comes next in terms of the service provision. And I'll leave it there because if I say much more about the number of people that are accessing particular aspects of the service, they are relatively small numbers, which will get quite emotive versus a commercial aspect to some of the services that will be provided. Let's have that discussion offline in the groups rather than in this meeting, I'd suggest, given the time this evening.
Okay, and this one, if you could perhaps respond to about the dermatology and the lighthouse.
Certainly. So very briefly, we have a current service contract between the ICB and the Trust. The Trust subcontract that service to Lighthouse Medical, which is the dermatology provider. That service comes to a natural contract end at the end of March next year. So that contract comes to a natural end at the end of March next year. There are active ongoing discussions through a procurement process, which I can't obviously go into in this meeting with what comes after that. But we're hopeful, very hopeful, that that will be a positive outcome for the population of the island. In year, there has been some discussion about the cost that's been proposed by the Trust to the provider. My understanding, and unfortunately no one's here from the Trust at the moment, is that has been resolved as so a non-issue in year.
Sorry, does anybody want a question to that? You did.
Chairman, can I ask under this, if pharmacists and dentists come to that, now have direct representation on the ICB, ICP, I believe in line with government recommendation?
I'd have to actually confirm that. My understanding is they have representation on the ICP.
Councillor Downer?
Thank you, Chairman. Yeah, I'd just like to ask about these online repeat prescriptions. Are they delivered by courier or is it by the post? Because say if the post got delayed and those medications were delayed and people were about to run out, how'd you get on then? Thank you.
So the obvious, the honest answer is that it's a combination. It really does depend on who the provider is, councillor. We can have a look at that offline because it is going to be an issue for just about anyone that's ordering prescriptions online. But happy to look at that offline. I agree with you with the level of risk through that online service is different to popping into a local pharmacy.
My understanding is that they factor that in. So you may get your prescription renewed a week earlier than you would actually need it to allow for a delay in post. And we do have to respect the fact that there is a patient's choice to choose to do that. Some people find it very useful indeed to have that delivered when they're not there, for example, when they're working or whatever. So people are choosing to access pharmacy services that way. But as I say, I understand that is adjusted in the recall of medications.
Joanna, and then last question from Councillor Mosda. Right, and please come back onto the committee, then you can be much more involved.
I'll try and make it brief. I just wanted to make a point that some people haven't chosen to use online services. They've been kind of forced to go down that route, partly because that they would rather go to their pharmacy, but the queue in their pharmacy can be hour and a half long. And we've had some people that want to use their local pharmacy, but they've shut at short notice many times, and that's led them to use an online pharmacy. So they haven't wanted to, but it's because of problems at their local pharmacies. And generally that's with the larger chain pharmacies. We generally get really good feedback about these small independent pharmacies. It's the larger chains where there are most issues.
It's just a bit of advice, really. Having a husband who's absolutely hopeless at remembering his heart medication, the 111 emergency prescription service that you can go to any Boots or anywhere, or Lloyd's Farms or anywhere in the country and actually have issued practically straight away, as long as you give the postcode, enough emergency prescription to tide you over is always good to hold in your back pocket, especially if you've got someone who's as forgetful as my husband.
Thank you for that. Go to the next item. Which is the work plan. We've got it in front of you. All I'd highlight on the work plan is that we've obviously changed the style of the committee meetings with more voice, and we intend to do that with mental health at the next one. In the interim period, sorry. In the interim period, I and Joanna from Health Watch are going to sort of visit projects and visit services. So we have a particular sort of understanding of the services and update before the next meeting. Members' questions? Okay, I now, what's right? Oh, thank you very much. Yes. We had a written question about a resident having a hip replacement and was told they were likely to be waiting up to 60 weeks. And the national target is 18 weeks. And the question was, he has waited 38 so far. Why is the Isle of Wight so behind target? And what do the integrated care board plan to reduce the waiting times? I'll just read out the response from you, because you gave a written response. Firstly, it's important to apologise to any Isle of Wight resident that has to wait for treatment. Currently, all providers of care are trying extremely hard to reduce the length of time patients are waiting for treatment, and the Isle of Wight Trust is no different in that regard. In fact, although it offers little in the way of comfort overall, the Isle of Wight Trust is actually performing better than the national average in regards to length of time patients are waiting for elective treatment, and in this case, a hip replacement. There are a variety of reasons for this, for the longer than required waiting times. All providers of care are still reducing a large backlog of elective treatments that were not able to be provided during the COVID pandemic response. Again, the Isle of Wight Trust has performed well in comparison to others. The demand for care for our on-island emergency patients often exceeds our available capacity and results in less capacity for elective patients, and therefore increases the waiting time for patients. Here, the Isle of Wight Trust has tried to maintain elective capacity at all times to continue to reduce the length of time patients waiting. However, this is not straightforward as emergency demand fluctuates daily. In summary, this is a significant challenge for all providers, and a large number of patients are waiting over the 18-week indicative period. The national policymakers are trying to work through a transition period where more practical targets can be available to our communities to better manage expectations. As commissioners and providers of services, we apologise for this situation. But we are reassured that the Isle of Wight Trust is doing everything it can to reduce the waits for patients and to risk assess whether there are impacts to patients during the extended waiting time. It is not appropriate to comment on individual cases, of course, and if further detail is available outside the meeting, we would be happy to review. Sorry. I will pass this on particularly to the new councillor, Sarah Redrup, who wrote this question in for one of her constituents within Wootton. So I'll pass that on, and she can then liaise with that resident to privately contact you about that case. Thank you. I now officially end the meeting. Thank you.